Hello, this is Dr. Dheeraj Masapu. I'm a consultant anesthesiologist, and today we have Dr. Sharmil with us, and he is the final year cardiac surgery resident and from Sri Gangaram Hospital. So, welcome to the channel, Dr. Sharmil.
Very nice meeting you, sir.
Yeah. So, in this video, we, as in my subscribers want to know about the 6-year program of cardiac surgery. And so basically how your any kind of hospital, what is the program about, and what kind of surgeries are being done in your hospital and other hospitals, and what is the scope of cardiac surgery in future, what is the books that you read. There are several areas actually we would like to know.
Yes, that's fine, sir. So I'll just start off giving a basic overview of how the course works and what is it that cardiac surgery actually consists of. Cardiothoracic surgery is the branch that the DNB offers as cardiothoracic and vascular surgery. So it has basically three components: cardiac surgery, thoracic surgery, and vascular surgery per se. Now, cardiac surgery itself has two different subspecialties at least. So one of them being adult cardiac surgery and the other one being congenital cardiac surgery. Now, adult again gets divided into subspecialties. There are people who are dealing with only coronary bypass surgeries. There are people who are doing only valves. There are people who are doing only valve repairs per se, and there are people who are doing what we call as aorta. So aorta is subspecialty basically. That's how it works. So this is basically the scope of the branch. So you basically get into cardiac surgery and then you keep on sort of subspecializing and then you basically end up doing some particular part of the heart that you want to deal with, and you keep doing that. So that's how it is. Thoracic is basically the entire mediastinal cavity except for the heart. So the pericardium and the pericardial cavity belongs to cardiac surgeon, thoracic surgeon. Now the problem with the cardiothoracic and vascular surgery per se that I see is that vascular surgery itself has developed into a super specialty. So they have what we call as DNB or MCHSS seats. Similarly, thoracic surgery is developing into a subspecialty and a super specialty on its own. So a lot of work that used to be done by cardiothoracic and vascular surgeons previously. Nowadays, the CTVS mainly focuses only on cardiac surgery. Most of the hospitals, most of the courses that are basically conducting this DRNB program would be focusing mostly on the cardiac surgery part. There are certain hospitals where the thoracic program and the cardiac surgery programs are integrated. So, what I mean is there are certain surgeons who do both thoracic surgeries and the cardiac surgeries. In these hospitals, you would get basically there will be no what do you call the delineation in these hospitals or with those consultants. Otherwise, the subspecialties are delineated, and in the hospitals where these subspecialties are not working together or they are not integrated with the same department, you basically get to rotate there. So in our hospital, it's about a 3-month rotation. There are certain hospitals where it is a 6-month rotation. There are certain hospitals which do not have the subspecialty, so they might send you to another hospital where the subspecialty is happening. So that's how it is. Vascular surgery, the exposure is usually bare minimum at all of the centers because vascular surgery itself has developed into a very large subspecialty, and they have their own way of working now. They've mainly most of their procedures have now become endovascular and stuff. So
Got it.
that's how it is. So that's why, yeah. So that's how it is. So the scope is very large. It's not just that you just get into the branch and you're just going to become cardiac surgeon, but the cardiac surgery then gets divided into a lot of subspecialties, and eventually you have to choose one of those and you have to master that, because to master all of these things simultaneously is something I do not seem very feasible.
Disease burden wise, cardiac disease is number one in the world according to
Yes,
statistics.
yes.
So patient base is more.
Patient base is more. That is why. The misconception that I face most of the times when the students that interact with me during the counseling process and when they're trying to pick up cardiac surgery as a branch, one of the most misconceptions is that cardiology or interventional cardiology is doing a lot of procedures, and hence cardiac surgery is going to be obsolete or cardiac surgery will not exist in the near future. This is the biggest misconception that I usually come across. What I want to clarify is that yes, they are doing interventional procedures. Yes, there will be a lot more procedures that will be done in the near future, but that does not mean that the cardiac surgery is going to be extinct. What I feel is that these patients will be the patients who either cannot undergo surgery for due to prohibitive risk of the surgery itself, or these will be the patients who are very select few. Not all the patients will be eligible for these interventional procedures, and cardiac surgery is going to say. The problem with this is that most probably the more simple cases would go to the interventional person, and the cardiac surgeon would be operating on more complicated cases. So that would mean that you would be doing more high risk, more complicated procedures rather than doing the straightforward procedures. But the branch is not going to go extend any time near.
Got it. I was about to ask that question, but you answered before I asked. Because you must have heard this question from different sources, I think. Yeah.
Oh, I hear it multiple times, million times a year, because also I do conduct my own webinars where I invite cardiac surgery residents from different institutes, and we interact with the aspirants whenever it is possible. So that's how it has been. So I have been interacting with the with the aspirants a lot in the last 3 years or so, and this is a question which is common for each one of them. 100% of the candidates who want to take up the cardiac this branch have this question in their mind, that we have spoken to so and so, and they have all told us that cardiology has taken over cardiac surgery, and cardiac surgery is not going to exist. So that's something.
Got it. So
Even the bypass surgeries, I don't think we are doing any less number of bypass surgeries nowadays. In fact, we are doing more and more bypass surgeries because more and more angiograms are being done. So
now, actually, what happened is a lot of young are getting cardiac disease. I'm seeing in my hospital.
yes. Even in my hospital, in the last 5 years or so that I have worked here, I can see the trend, becoming younger and younger patients. Recently, we have been operating even on 40-year-olds. So
Is there any specific reason that you guys are thinking about?
specific reason for what? Why younger
Yeah,
patients?
yeah.
One of the reasons, I don't see any specific reason. I think it's a lifestyle thing
Okay,
mostly. A lot of the younger patients are under a lot of duress, a lot of stress.
got it.
That could be one of the reasons. We do not have any specific reasons per se. The only other reason that I could think of, from whatever I have read, is that anyways our population is more prone to cardiac disease as such.
Got it.
That's how it is. The Southeast Asian population is very prone to cardiac disease,
Got it.
because of lifestyle or whatever. But that's how it is, and the current lifestyle is not helping.
Yeah.
More sedentary and more stressful life. It's not helping. It's only deteriorating things.
So, how is your day in the life as a resident in cardiac surgery?
Right. This is another thing that I would like to clarify very, very to all of the people who want to take up cardiac surgery. This is a very hectic branch. Because our surgeries usually we tend to go in thinking, okay, this could be a 3-hour surgery or a 4-hour surgery. And there are times when you do not get out till the next day. It could be that complicated. And there are times, and even if you're doing 2 surgeries a day, it just means that you're scrubbed in for 8 to 10 hours, just scrubbed in. That means that you're spending more than 12, 13 hours in the hospital anyways. On top of it, if you have your duties, you're going to stay there. And it might be that next day morning you have another case and you might have to scrub in because there is nobody else to scrub in. There might be such cases. You might have acquired those skills. So the problem with cardiac surgery is, as you grow senior in the field, as you become a more senior resident, you tend to get more skillful. You tend to learn more things, and you might become a part of a particular surgical team, and for them you might become indispensable. So that means that you might actually be doing 24-hour duties, and next day again you're scrubbing in for 2 cases and you're scrubbed in for another 12 hours. So that could be very well be the case scenario. You should be basically ready to do such things. I mean, because that's where because this is a branch which has anyways a very long learning curve. uh, by not doing so, what I feel was, whenever I'm doing such things, so there are times when I feel that maybe when there are certain people who think a little more of, okay, I can't do this much. So it basically doesn't do anything. It just, I think, prolongs the learning curve. That's all it does. But it is a hectic branch. It takes a lot of.
So it is not for everyone.
It is not for everyone. It is not for everyone for sure. It is an unforgiving branch. The stitches that we take, sometimes a single stitch can basically kill a patient. One stitch taken wrong here and there, and you might basically damage, say, SA node, or you might basically occlude a coronary artery, and the patient might not come off bypass and stuff. it's just very unforgiving, and there are days when you might do something, just a single stitch gone wrong, and you might end up not salvaging the patient, and that's very, very soul crushing in a way.
Yeah. So it is.
So it's an unforgiving branch. It requires a lot of dedication, and it has a very long learning curve. So a 6-year residency is not enough. Even a 6-year residency is not enough as far as I'm concerned. I think you might have to, uh, go ahead, at least work for a year and a half before you start choosing your.
Got it. So basically, what I'm trying to ask is, so there is some person who is very sensitive, and but he got a good rank. He can get cardiac surgery, but he's a very sensitive guy, and a little panicky, and such kind of people are there among doctors also.
Yes, yes, yes,
It is not for
yes, yes,
him.
yes. It is not. I see. It's per se. I do not think that a sensitive person cannot take up any surgical branch or anything. What I feel is it's about adapting. Eventually, it all comes down to adapting. There might be a person who might be mentally strong, but he might not be able to take the long working hours because of the physical part of it. There will be people who will not be able to take it because of the mental part of it. So it all comes down to eventually how you basically adapt to the situation. But having said this, I think it is not for everyone. It is not for people who cannot basically handle a very stressful environment. This is a very stressful environment, and this is an environment where you do not know. Even your post-op patients are always at risk. The initial 48, 72 hours, patient might be extubated, off inotropes and everything, and suddenly the patient might just collapse.
Got it.
And
Got
you
it.
may have to, you may be the only person in the ward who might have to do something about it.
Got
So
it.
it's always a stressful. It's always a very stressful environment, and yes, so that's the part. I mean, person who can handle a little bit of stress, that's fine. There are people who cannot handle it, then they cannot just handle it. It becomes too much for them.
Got it. Got it. So basically, how is the studying part apart from the working and this one? What is the kind of books that you need to study during the 6 years for exam?
See, for exams, sir, what I would say is I am somebody who believes that one shoe doesn't fit all, right? So there are various kinds of textbooks, and it will eventually come down to what you understand better. So there is
Okay.
something called as Cons Adult Cardiac Surgery. There is the standard book that most of the physicians, most of the consultants would refer to you is what is called as Kirkland's Cardiac Surgery.
Mm.
Kirkland's Cardiac Surgery has both adult and the congenital part in it. But personally speaking, even so for somebody who has even a little bit of language difficulty with like English, it's a difficult book to understand. So so that's the problem. So there is another book called as Sebastian's textbook of chest surgery. Basically,
Got it.
even that book has that Sebastian's has all three parts. So thoracic, it also has adult cardiac, it also has congenital part. It's a little easier to understand as compared to Kirkland, but it does not have as many details as Kirkland. So eventually, it will come down to choosing. Congenital surgery itself has, 2, 3, 4 books that can be used. Moss and Adams is there. There is something called as Konstantin Mavroudis textbook of congenital cardiac surgery is there. Robert Jonas, there is a textbook by Robert Jonas. All of these textbooks are there, and it eventually will come down to a particular person what the person understands. That's what I feel. So personally, if there is somebody who understands Jonas better than say Mavroudis, I would say read Jonas for. I mean, that's what matters is how you understand things, how you understand the concepts. So whatever the book, there are a lot of options to read. So eventually you'll have to read those, sample chapters or something, and then you eventually choose which book you understand better and where you get your concepts right. That's how I do it. And the other thing that I think as a postgraduate resident that I like to do is I just don't limit myself to the textbooks. So I might read a textbook, a chapter from the textbook. Then I would go back to, say PubMed or something, and I start searching for review articles there.
Good.
I'll read a review article which has been published more recently. The textbooks, I think, say the last textbook that we have published is in 2018. In 5 years, a lot has changed. And and I, for one, believe that a textbook which has been published in 2018, the data there would be of most probably 2015 or 16, not later than that.
Yeah.
These are big textbooks which get reviewed over a period of a year, and then they get published. So I think not later than 2016. So that even increases the gap by 7 years, 6, 7, 8 years sometimes.
Significant.
And yeah, so 8 years is a long time, and 8 years can change a lot of things. So you need to, sort of be in touch with what is going on currently. So I tend to read a lot of review articles myself, and from the review articles, I mean, I might find some references for something, and I might actually end up reading those also. That's how I eventually personally read. Not everyone does that, but that's how it is, and that's how I approached my post graduation.
Got it. How many exams are there before you get a degree and become a cardiac surgeon? How many exams do you have to pass in your 6 year period before you become a cardiac surgeon, before you take certificate?
Yes, so there are two exams, two parts in which the exam is conducted. Both of the exams have two papers each.
Hmm.
Rather than say if somebody who is appearing for DNB, what you call as broad specialty, they appear for four papers.
Yeah.
We appear for two papers in two parts. So there is part one, which is usually conducted at the end of second year, and you
Okay.
become eligible to appear for part two at the end of fifth year.
Hmm.
So part one has two theory papers. One is for cardiac surgery, and one is for general surgery.
Okay.
So the NB curriculum says that the part one, when you are being tested for general surgery, it is to be tested on basic principles of general surgery rather than the entirety of the general surgery. But it is not actually very adhered to very strictly, because one of the general principles of cardiac surgery also includes oncology, and they sometimes get into the depth of it. But it's not something which is not manageable. You can manage it. I mean, it's not that difficult. Cardiac surgery, again, they're supposed to ask you basic questions regarding the cardiac surgery. Cardiac surgery papers are usually okay. They don't tend to basically deviate from the agenda. So sometimes if you can make up in cardiac surgery to what you might have missed out in general surgery part. So that's how it is. There is a practical part to the exam also. The practical part is basically case presentations in cardiac surgery. They do not involve any general surgery at all. So practicals are completely cardiac surgery. So you will go in and you will present usually four cases. They're all short cases and viva voce. And the second part of practical exam is OSCE for general surgery. So you present cases in cardiac surgery and you appear for OSCE in general surgery. 25 questions, 6 marks each. Again, quite manageable.
Got it. So,
And the second part of the exam, the fifth at the end of fifth year, is again it's completely cardiac surgery, obviously. So two papers in cardiac surgery and a theory part and practical part in cardiac surgery. So that the practical does not. It's a 300-mark practical straight away, four quizzes.
Got it. So,
And wall rounds.
Yeah. And so basically, you are studying in Sri Gangaram Hospital. So students who are watching this interview, what other hospitals you recommend? Yours is good actually. That's what you already told, that yours is a good hospital. Apart from that, any other hospitals?
Apart from that, the best hospital to do residency as far as the DRNB 6 year post CTVS is concerned, I feel is GKNM. G. Kuppusamy Naidu Memorial Hospital. It's in Coimbatore, one of the best hospitals that I know of. They have a lot of affiliations. They have a lot of international faculty coming in and teaching and stuff like that. And from what I have heard from the residents there, I believe that they're also getting very good hands-on training there. The academic part is very strong, so it's. I think it's one of the good institutes to do. Naran Hridayalaya Bangalore is a very high volume center. They're doing more than 1,200 surgeries a month, which is a very, very high volume center. And it is one of those centers where you get to see everything. They have very strong academics and stuff like that. So those are the two hospitals that I think very highly of. The rest of the hospitals, see, the problem is it's very difficult to segregate the rest of the hospitals, because apart from these two hospitals, none of the hospitals say, even GKN does not have this caseload of NH. So it's like that. So every hospital has its pros and cons. So most of the hospitals will have some pros and some cons. So it becomes very difficult to segregate them, particularly ki, this is a better hospital than this. So it eventually comes down to a personal choice. Okay, what is more important for you? So there are certain hospitals in Delhi which pay a little higher stipend as compared to other hospitals in, say, in South or anywhere. So that's how it is. As far as the academics is concerned, so again, this is the part where, so there are certain hospitals where the academics is not that strong, but hands-on is good. There are certain hospitals where academics is good, hands-on is about average, and hands-on also depends on the consultant's trust on you. So what happens is there are certain hospitals where everything is basically staged. So they have a fixed protocol. So a first year does this, second year does this, third year does this, fourth year does this. But most of the hospitals do not have it. They do not have that structured program. What happens is that you progress as you progress. So you are allowed to do something. So until you do it satisfactorily, nobody is going to give you some more work. So that's how most hospitals are. And until you get to your fifth or sixth year, there is certain things which are not given to you in most of the hospitals. But in the end, I feel that when you complete see this DRNB core from most of the hospitals, your basics are instilled in you. So you know how to harvest all the conduits, you know how to open a chest, how to close a chest, how to put a patient on a cardiopulmonary bypass, how to come off cardiopulmonary bypass. Uh, in the best case scenarios, you might even know how to do a proximal anastomosis. There are certain hospitals even better that. So if you the apart from this, up to the proximals, it is more or less guaranteed in all the hospitals. But apart from the proximals, the distal grafting, the grafting on the coronary artery side is something that is not given to everybody. It will depend on your skills. It will depend on how well you have worked during those 6 years, and it will come down to that. There are a lot of again. This is one of the most commonly asked questions to me when I'm basically interacting with the aspirants. Is that when can I do independent cases? Now, independent cases is again a very individual thing. It will come down to how well you are able to cope up during your 6 years. So, in our institute, we have had students who have done 15, 20 independent cases by the time they went out, and we have had even students who did not know how to do a proper sternotomy. So that's how it is. That's how the range is. So somebody who basically cannot do even the basics right, and somebody who has done 10 to 12 cases, 15 cases, 20 cases on an independent basis. So this is something
Yeah, it is.
which is it is quite
Depending, it depends on resident basically. That's what.
yes, yes. And but again, having said this, I'll not say 20 cases doing individually is the norm, but I'll not also say that somebody who cannot do a sternotomy properly is the norm. The norm in our institute is that we get to do all the basic work. We are taught all the basic work. We get to do all the basic work. One of the most important reasons why that happens in my institute is because part of the work that is being given to a junior is being decided by the senior. We
Okay.
start the cases, we end the cases, so we have the autonomy to decide. Okay, this student is working well, so I can allow him to do this much on my responsibility. That
Good.
is being allowed uh, by the grace of our consultants. So that's something that happens in my institute. I do not know how other institutes work, but most of the institutes have this thing where you will get out knowing all your basics. That's why I'm saying the advanced skills require a little more training. You may have a bite of your advanced skills during your residency, but you will not be able to hold or grasp them completely in that period. Not everybody can, at least. I mean, I think on an average 90% of the students won't be able to have a complete grasp of advanced skills of cardiac surgery during your residency, and you may have to spend about a year or so acquiring them. And then you can basically decide on what subspecialty or what fellowships you want to do. You may decide not to do any fellowship and just pursue whatever work that you have learned during your course, and you might be fine with it. And if you decide to do a fellowship, then there are multiple options, and then you can just end up doing one of those fellowships and then come back and do whatever you wanted.
What are the fellowships commonly being done after cardiac surgery?
Okay, so as I said when we started off, there are subdivisions and sub-subdivisions. So adult cardiac surgery. So there are fellowships purely in adult cardiac surgery. And when you say adult cardiac surgery, then they rotate you in various fields: valves, repairs, then minimal invasive cardiac surgery, then mechanical circulatory support and heart failure surgeries. So then aorta. So these are four major subspecialties as far as the adults are concerned. So there are fellowships in adult cardiac surgery where you rotate in all these four subspecialties, or you can pursue one of these subspecialties as a fellowship as well. Then there is congenital cardiac surgery. Congenital cardiac surgery runs completely different, and it's usually a 2 year fellowship at least, a congenital program, and it's completely different from adult. So
Got it.
that's
If we leave the fellowships after DNB, if we have to get more hands-on, which centers are better in India to apply?
Oh, that's a difficult question to answer because again, so the way I have seen it, the way what the people have progressed is that uh, So once you leave your center and you go somewhere else, you need to re-establish your credentials, because you may tell them that I can do this, I can do this, and I can do this. But unless they see you actually doing it and doing it properly, they won't believe you. And for them to actually see all your skills, it takes usually up to,
1 year.
another five.
Yeah.
Yeah, it's anything in between 6 months and 1 year.
Yeah.
So usually there is a slowdown period in between. There are, I don't know how many centers actually, basically go ahead and take you on your word and start giving you work that way. I mean, I'm not very sure of this. So it's a
Got
very
it.
difficult question to answer.
Yeah. So about we'll come to the end of the video. Stipends we'll just discuss overall India wide. If you see, it varies based on the college. I know that, but roughly, how much can a student get in different years?
So the salary for the 6 year course basically is divided into two parts. So the first part is first, second, and third year, and the second part is fourth, fifth, and sixth year. So what happens is in the first, second, and third year, you basically get the stipend that is equivalent of DNB broad specialty. So somebody who is doing say DNB general surgery and somebody who is doing DNB 6 years, this part, they'll both get equal amount of salary. Fourth, fifth, and sixth years, you basically get the salary that a DNB SS is getting. So you basically get promoted to a rank of SR. Again, there is basically a rule of NBE that you can be paid the salary of an SR only when you clear your part one. But again, this is a rule that is followed at the discretion of the institutes. There are certain institutes which follow it, to the T, and they say unless you pass your part one, we won't give you the salary of SR. And there are certain institutes which say we don't bother. We just basically, first, second, third, fourth, fifth, and sixth. On an average, currently, I think the salaries that people in the broad specialty are getting is between 40 and 45. This is on an average. There are certain institutes which are giving higher. I don't think there is a lower salary right now. 40 is at least the salary that people are getting in most institutes, irrespective of the state. I'm not aware if there is anything less than 40, 45. Usually, by the time you reach your fourth year, the salary rises up to 65 in the institutes where there is the salary starts at 40. As far as Gangaram Hospital is concerned, we start off at 76 in the first year, 76, 78, and 80 in the first 3 years. And then the salary, once you reach the SR level, is 1,03,000, 1,06,000, and 1,08,000.
Yeah, got it. So that is variable actually. In South India,
it is very variable. South India, it's quite it's less. Even in North India, the salary is quite. Even in Delhi, even the institute to institute, the salary varies.
Correct. So then
average salary in Delhi is around 55,000.
Got it. So we covered, I think, almost every aspect a student needs to know. Do you want to add something else to a budding young NEET aspirant?
So what I would like to add here is that the other question that I get asked most often by these aspirants is, why choose a 6 year course? Why cannot I go through a 3+3 pathway? I don't have a definite answer to that. What I'd like to tell people is that you should not choose a 6 year course if you're unsure of it. Do not get into a 6 year pathway unless you're more or less sure of the branch. And even if you're not sure of the branch, you should be aware that what you're getting into. So know the branch, what you're getting into. Think of it before you fill in the choices and you go in and go into the counseling and accept the branch. One of the ways, because see, one of the biggest problems is that because these are all super specialty courses, whether it be a neurosurgery course, a 6 year course, a cardiac surgery course, plastic surgery course, pediatric surgery, I think is a little different from other three branches, because pediatric surgery is basically general surgery itself in pediatric patients.
Yeah.
So it might not affect somebody who has surgical inclination. He might actually be able to bear with pediatric surgery better than the other three specialties, because the other three are actual very super specialties, and they do not have the general surgery component as much, especially the neurosurgery and cardiac surgery. Plastic surgery might have a little bit of general surgical principles coming in, but from the way I see it, neurosurgery and cardiac surgery are very highly super specialized fields, and most of the people who do neurosurgery, although they have the surgical basics, surgical basics, right? But the skills that you acquire in general surgery, they are not utilized as much in cardiac surgery as well as neurosurgery. That's how I see it, because these two are branches which are basically dealing with microsurgery and whatnot. Even plastic surgery has the same problem, but plastic surgery might still, help have, that general surgery component. But I do not see neurosurgery or cardiac surgery having that component. What is the problem? It becomes a little overwhelming, especially because you are post MBBS, you have absolutely no exposure to the super specialty courses. You walk into the wards and you see there are your two seniors who are standing there and talking, and you listen to their talk and you don't understand anything. You feel they're talking gibberish, they're talking in French or German or something, and you absolutely get overwhelmed because you think, okay, I have chosen this branch. I thought I knew something about cardiology. Very overwhelming. So you have to be very aware of this, that okay, I'm getting into a branch which is very new to me. I'm getting into a super specialty, so I need to see. I do not see a problem with somebody taking a course and then leaving it. That's something. Sometimes it's just that sometimes you feel that you might be able to do surgery, you get into the branch, you go to the OT, 2 months, 3 months down the line, you realize this is not for you. It's absolutely okay to leave the course. But the problem with leaving the DNB 6-year courses is that you then do not get to choose a DNB course for next 6 years, even if you clear your entrance exams, right?
Okay.
That is the only penalty that the NBE has. You do not pay money and you do not get back into the system. So you're losing out on an option. Once you leave the course, most of the times, most of these aspirants will go back and start preparing. So if you're going to go back and prepare, you're putting more pressure on yourself because you know that you cannot opt for a DNB course. The only option that you have left is an MD or MS course, in which case you need to be securing those, for first 3,000 or 5,000 ranks to get a good choice, good college or what.
Super.
That's the problem. That's the problem of leaving a 6-year course or any DNB course per se. That is why I tell all these aspirants, be very sure about picking a course. And if you're sure and if you have taken it, then you will be able to, sort of get into a mindset where, you anticipate this. You have to understand that you're going to get into a super specialty because I'm going to get my difficulties in the first 3, 4, 5 months. Once you get into that mindset and get into the course, it becomes a little easier because then it is not so overwhelming. Most of the places that I know of, the seniors are understanding of this fact. Although sometimes we come out a little strong just to teach, but we do understand that this is a problem. Especially in my institute, we give a basically what do you call first 3 months are basically sab kuch maaf hai. You can do, you can make, yeah. So everything you do goes through a senior, anyways. And even if you make mistakes, we're not critical of it. We come back and try to tell you, okay, this is what you did, this is how it should be, and why this should be such happening in this way. That's how we approach things. I think, and that is how it is in most of the institutes, except there are always different kinds of seniors and different kinds of people. So there might be some people who might be a little harder than this, but most of the institutes, I think most of the people that I know of are similar to, the approach is similar. So that's the only advice that I tell people before getting into a 6-year course. At least be sure that you like the system. You cannot get into cardiac surgery thinking of, okay, I always wanted to do general surgery, I'm not getting general surgery, so I'm going to take up cardiac surgery.
Got it.
That is not something that I would advise a lot. You have to at least know, okay, I can deal with cardiovascular system. This is something, while I was doing my MBBS, was I able to understand what cardiovascular system was about, or whether I was able to understand what CNS was about. If you could understand and if you could bear the subject, then most probably you'll end up accepting it. If you could not stand the subject and you enter into a super specialty course,
then
you have to deal with it your entire life, you're stuck. That's the problem. And that's the only thing that I usually try to emphasize upon. So 6-year courses are not bad. They are in fact actually very good, because even after all the rotations, you spend more time in the core branch as compared to an MCH course. MCH course is only 3 years, of which, say, I would say last 6 months you basically deduct for examinations and everything. So that's a 2.5-year course, of which again the first 6 months go into the orientation. So that's about 2 years that you get in there. In here, you get about 4.5 years in the core branch. So even if you deduct the first 6 months and another 3 months for exams, or 4 months or 6 months for the exam, so you still end up getting 3.5 years in the core branch as compared to say 2 years or two and a
More
half years in
exposure.
the
Yeah.
more exposure. So you get to see more things.
Got it.
So and you possibly get a little more hands-on as compared to
Got it.
MCH. I'm not saying this for sure because there are different institutes, and
Yeah.
even MCH there are institutes which are wonderful. So
Even in the same institute, it's individualized again based on the resident.
individualized again. Yes, yes, yes,
Yeah.
yes.
So
That's how it is.
multiple factors are there. So thank you, Sharmil. So this video is going to help many students who want to take up cardiac surgery. And
Most welcome, sir.
thank you very much for coming into the channel.
Most welcome, sir. Most welcome. There is one bit of information. The
Yeah.
webinar that I was talking about, with the residents, with the aspirants, we are doing it this year also. We're doing it on 13th of August.
Okay. Link you please give me. I'll put in the description. And
Sure, sir. I'll give to you. There is a registration
Yeah.
link for now because I do not know how many participants are going to be there. It will be
Yeah.
depending on the participants. I'll choose the platform.
Sure.
So I'll just share the link
You
with
share
you
the link. I'll
on
put in
WhatsApp.
the
Yeah.
description of this particular video, and interested people will join.
Yes. Please.
Okay.
Thank you, sir.
Thank you, Sharmil. Thank you very much.
Most welcome, sir.
Yeah. 1 second.